very much. And it's a great pleasure and honor to be participating in one of your webinars. And I hope that I will be able to impart some of my words of wisdom gleaned from over 30 years of practice in the UK, looking after patients with severe premenstrual syndrome, or the severe form of premenstrual syndrome, which is the premenstrual dysphoric disorder. As a basis for my presentation, I'm going to use the definitions, guidelines, management and research recommendations from the Royal College of Obstetricians and Gynecologists, and these are also summarized on our NAPS website, pms.org.uk, which is the UK organisation that looks after sufferers that I chair. These are my financial disclosures. So I'm sure anyone who's logged on to this webinar believes that it's time that this condition was taken more seriously, socially and professionally, amongst the public, amongst politicians, and also amongst healthcare providers. In the UK, we have a women's health strategy, which was published last year, that we believe will finally provide some much needed guidance as to how we should be managing distressing conditions such as this, which I believe in the past have been neglected. So this strategy is going to provide the template, but it's of course still important that there are adequate resources provided to deliver these clinical services, to provide the education required to deliver these services, and also to provide the research required so that we can practice in an evidence-based way and also using evidence-based products. Just a word about NAPS. We were originally called the National Association for Premenstrual Syndrome, but recognizing that there are many variants of this syndrome, we renamed ourselves syndromes. But we believe that the PMS terminology is still useful because PMDD refers to one particular type of severe form of PMS, whereas perhaps premenstrual syndrome is a more all-encompassing terminology. Another way to refer to it would be premenstrual disorders. Whatever happens, I think it's vital that there's universal recognition that the severe impact that PMS can have, whatever terminology is used. And the really important issue is education of the public and healthcare providers. Again, this audience needs a little introduction to the issue of PMDD. It is a severe form of premenstrual syndrome as defined by the American Psychiatric Association. So over the course of a year, during most menstrual cycles, 5 or more of the following symptoms must be present, including depressed mood, anger, trouble concentrating, lack of interest, moodiness, increased appetite, insomnia, feeling overwhelmed, and other physical symptoms, including bloating, breast tenderness, and headaches. These symptoms should be severe enough to disturb your ability to function in social work or other situations, and the symptoms should not be related to or exaggerated by another medical condition. Otherwise, that's what we refer to as PME, premenstrual exaggeration or exacerbation. The International Society for Premenstrual Disorders, which was set up by Professor Sean O'Brien from the UK, talked about the definition of PMS and referred to the core premenstrual disorders and the variants of these premenstrual disorders as a way of differentiating the different types of condition. So the core premenstrual disorders were the classic PMS with ovulatory cycles, functional impairment, and postmenstrual resolution. And the variants included PME, which I mentioned earlier, which can be exacerbation of conditions such as epilepsy, migraine, asthma, and psychosis. The non-ovulatory premenstrual disorders, where there is ovarian activity, but not necessarily ovulation every month, for instance, in PCOS. The progestogen or progestin-induced types of premenstrual symptoms, for instance, caused by the combined oral contraceptive pill or hormone therapy, and premenstrual disorders without menstruation. So women, for instance, who have had a hysterectomy or had the uterine lining taken away can still have cycle-related symptoms, but in the absence of bleeding, in the absence of menstruation. So we recognized at the Royal College of Obstetricians and Gynecologists in the UK that there was a need for a consensus and guidelines on management of severe PMS, and that this was essential in order to encourage acceptance of the condition by patients and healthcare professionals and the regulatory authorities, and also to encourage evidence-based practice. So we produced the first iteration of that in 2007, and this was updated in 2017. And you can access this through the RCOG website, rcog.org.uk, and that's the Green Top Guideline number 48. And I'm very grateful to my collaborators, not just Sean O'Brien, but Lucy Baker and Michael Craig, who is a psychiatrist also with an expertise in gynecology. In fact, sometimes we refer to him as a gynecologist, who provided very valuable input into that guideline. We have other sources of information as well, obviously a plethora of information on the IAPMD website, which I very much commend to you. As far as the UK is concerned, we've also produced a condensed version of the RCOG guidelines, which are these pink NAPS guidelines available at pms.org.uk, and also recently published a paper in the Obstetrician Gynecologist reviewing the latest information on the diagnosis, pathophysiology, and management of premenstrual syndrome. And those are my co-authors, once again, to whom I am indebted for this publication. The prevalence of PMS or PMDD varies according to the type and location of the survey conducted, and clearly there are global variations, and I understand that you are joining us from all over the world for this webinar. The peak prevalence appears to be at a time when ovarian function becomes more erratic, if you like, and hormone fluctuations become more exaggerated, which is typically in the 35 to 45-year age group. Moderate premenstrual syndrome was found to occur in 24% of women in an area of the UK, Southampton, in which there was a survey carried out by one of our NAPS colleagues, Carrie Sadler. Severe PMS or PMDD is thought to occur in 5 to 8% of the general population, but in one study they actually found a 23% incidence in perimenopausal women, where women were also suffering with menopause symptoms. The prevalence appears to be slightly lower in Asian countries compared to Europe and the US, but that may be because it's not reported, not because it's not occurring. You know, I think we do need to do more research into the cultural aspects of this condition. There does seem to be a higher incidence of PMS or PMDD if there has been a history of prior emotional and physical abuse. As far as the etiology is concerned, there appear to be multiple theories. One is that there are variations in the impact of the estrogen serotonergic mechanism, and the other is the impact of the progesterone allopregnanolone GABA system. So as estrogen levels fall and serotonin levels fall, that can trigger symptoms. Also, as progesterone levels rise, allopregnanolone levels rise, that can trigger the GABA receptors, and in women who are predisposed can lead to depressive effects. And there have been interesting studies using functional MRI showing differences in PMDD sufferers. There probably is a genetic predisposition, and there have been these polymorphisms shown in the ESR1 gene by Goldman, Schmidt, Rubinow, and you'll see the publication in a moment that I refer to in greater detail, where these polymorphisms vary in PMDD sufferers compared to controls. But the important thing is that cyclic ovarian activity is present and that hormonal fluctuations are essential in the role of the genesis of symptoms. And in women who aren't ovulating, who don't have ovarian activity, for instance, in pregnancy or postmenopausally, these symptoms do not generally occur. So this is a publication I referred to, which at the time was referred to as a big moment for women's health by Professor Goldman, because it established that women with PMDD had an intrinsic difference in their molecular apparatus for their response to sex hormones, and that these were not just emotional behaviors that they should be able to voluntarily control. There have been other studies. Dubey et al., for instance, suggested that sensitivity may be attributed to dysregulation, overexpression of the ESCEZ gene complex in PMDD. John Studd, one of my dear colleagues who sadly passed away in 21, coined this triad of estrogen responsive depressive disorders, seen in the same predisposed individual who would suffer typically with postnatal depression. Then as time went by, this would lead to worsening premenstrual depression. And then as time went by, merge with climacteric depression, all, as I say, in the same genetically predisposed woman. And I mentioned earlier that, if you like, the proof that ovarian activity is integral to PMS etiology is that we have these stages with no symptoms prepubertally, during the latter half of pregnancy, and also postmenopausally. So how would I approach a patient with PMS or PMDD in my clinic? I think being receptive and listening is part of the art, if you like, of making a good diagnosis. Confirming the diagnosis with prospective symptom diaries, I think, is important. How often have we seen patients diagnosed or misdiagnosed with bipolar disorder when the cyclicity of the symptoms has been missed? We need to judge the intervention according to the patient desires. We should, of course, consider all interventions, but it may be that a patient doesn't want to use a medical intervention, or she may not want to use a psychiatric or psychological intervention. I think we should be flexible in terms of what we recommend and what we institute. We need to look at previous treatments as well, and I'm going to talk a little bit more about the treatment algorithm in my presentation. And we also need to judge treatment according to the severity of PMS, PMDD. If the symptoms are very severe, then we may need to start with GnRH analogs from the outset, particularly if lives are at risk. We need to review early at 3 months, but we mustn't place arbitrary limits on duration of treatment. And I, in some of my patients, continue treatment very long term through into menopause and beyond, where I switch women from one form of hormone therapy to another, which is tailor-made according to their stage of life, if you like, the life course approach. And as a gynecologist, I would co-manage patients with severe background psychopathology with our mental health services. I think we have to make the point that there are no proven diagnostic laboratory tests or investigations that make the diagnosis of PMS, PMDD on their own, and that the diagnosis of PMS is primarily made through looking at the cyclicity of symptoms. And we have a number of apps that can facilitate that. There's Professor O'Brien's Prementrix app, there's a Flow app, there's a Clue app, or if people prefer pencil and paper, then a diary such as a daily record of severity of problems can be used to record the symptoms. And that's so much more useful than trying to make the diagnosis through retrospective recall. Not everything has to be entirely publication and evidence-based. There can be some good practice points, as we published in our Green Top guidelines. And I think it makes common sense that we should give good advice about exercise, optimization of diet, reducing stress as much as possible, which can exacerbate the symptoms. We have to bear in mind that most treatments which are efficacious for PMS, PMD are evidence-based, but not necessarily licensed for that indication. And that's where we need more license preparations to give practitioners, particularly in primary care, the confidence to prescribe these preparations. Women with underlying psychopathology, as well as PMS, should be referred to a psychiatrist or a psychologist, and ideally the practice should be under the umbrella of a multidisciplinary team. I referred to a survey by IAPMD when I gave this presentation to our British colleagues, which was published on World Suicide Day in 2021, which showed that 86% of women with PMDD had considered suicide and 30% report at least one attempt during their lifetime. And suicidal thoughts, ideation plans, and attempts are strongly associated with PMDD, and all premenstrual disorders should therefore be considered as risk categories for suicidality. And it's therefore really important, and I work closely with Michael Craig, that hormonal management is coordinated closely with mental health teams, with plans in place for times when the woman has suicidal ideation and intent. So this is the algorithm which I referred to earlier in my presentation, which I think is a very useful aide-memoire for managing women with this condition. Of course, we should try simple interventions first of all, and all medical treatments should be underpinned by the optimization of lifestyle and diet, as I referred earlier. There is some evidence for complementary therapies, and I'll mention a little bit about the more evidence-based ones. There is also evidence for cognitive behavioral therapy. There is some evidence with some combined oral contraceptive pills, and there is evidence for SSRIs. As a second line, we would tend to guide our patients towards the use of hormone therapy at moderately high doses that will suppress their ovulation and provide a constant hormonal environment. And I will refer to that in greater detail in my presentation. I will also refer to the third line treatment, which is GnRH analogs with add-back hormone therapy. And I will also discuss the fourth line treatment, which clearly this is something we don't go to in the short term, but if women have been suffering for a long time, or if other treatments have not benefited them significantly, but we're sure about the diagnosis, then hysterectomy and bilateral oophorectomy with adequate add-back hormone therapy can be a life-altering procedure. As far as complementary therapies are concerned, again, I think we need better evidence. There's some evidence for vitamin B6. There's some evidence for calcium. There's a couple of RCTs on that. Isoflavones, there are a couple of RCTs looking at isoflavones from sources such as red clover and soy. Agnus castus appears to be the most evidence-based of the complementary therapies. And in this meta-analysis, which we referred to in our Green Top guidelines, 7 out of 8 RCTs showed a benefit, but unfortunately the lack of standardized preparations. And it may be that some of the preparations contain 4 milligrams of agonist, others may contain higher doses. So it's about finding what is the most effective dose for that particular individual, but I wouldn't start at lower than 4 milligrams. And some of the studies which showed efficacy were using 20 milligrams. St. John's wort, we've got to be cautious with this because it does interact with many medications. There is some evidence for its efficacy, but we need, again, better data. And one of the most commonly recommended but least evidence-based complementary therapies is evening primrose oil. So I found this cartoon in which it said she found if administered correctly, EPO had a remarkably calming effect. There we are with a bottle of gin, but not that I'm recommending that. But what I would say is that EPO can be helpful for cyclic mastalgia, and that's where it does come into its own, either evening primrose or starflower oil with a GLA content of 300. Myra Hunter has done quite a lot of research into managing PMS with CBT. Obviously, we know of the work in Chicago as well. When treating women with severe PMS, cognitive behavioral therapy should be considered routinely as a treatment option, but certainly in the UK, it is difficult to come by, and there can be a waiting list of a year to get onto a CBT program. But clearly, any unit managing women with severe PMS, PMDD should have a clinical psychology service. I'm sure Tori would agree with that. As far as data are concerned, I've mentioned one study which was published in our recommendations, in our guidelines here, where Myra Hunter compared fluoxetine 20 milligrams with CBT with combined therapy and found that the groups showed equal efficacy, and a meta-analysis of 5 CBT studies did show benefit. And I also believe that combined approaches are potentially very beneficial. But we have many patients who are having CBT and also have hormone therapy as well. SSRIs, we've got grade A randomized controlled trial data looking at various SSRIs, showing that modulating the levels of serotonin improves the psychological symptoms of PMS. There's even some evidence that some of the physical symptoms could improve, although that's less easy to explain. When treating women with PMS, PMDD, both luteal and continuous dosing with SSRIs can be recommended. I find a regimen that's particularly well tolerated is escitalopram, starting at a dose of 5 milligrams. In the UK, we have a suspension where you can actually treat with 1 milligram per drop. And this can be used in the symptom phase or luteal phase of the cycle. In my view, in women with perimenopause, they tend to do better with hormone therapy, but short-term treatment of symptoms can be used until cycle stabilization has been achieved hormonally. So I see the SSRI use in that population more as a sort of sticking plaster, if you like. What about the combined oral contraceptive pill? Well, this was one of the treatments that was used quite regularly, but with a limited evidence base, until the drospirenone-containing pills came along, which tended to be better tolerated, because I believe that the limitation in effectiveness of the pill was primarily due to the progestogenic side effects of some of the progestins within the pills, the older types of progestins, but also because many of the pill regimens were used with a 7-day hormone-free interval. So this hormone-free interval permitted the resurgence of ovarian activity and therefore the resurgence of symptomatology. There was a Cochrane review published of 5 RCTs with over 1,900 participants, which showed that the drospirenone-containing pills appeared to be the most effective for reducing the severity of PMDD. These are superimposed data published showing different studies, a couple of the drospirenone-containing pill studies, one parallel, RCT1 crossover study, and comparing the data to the SSRI pooled data from 13 RCTs, showing that the treatment effect seems to be fairly similar between those pills and SSRIs. So as I've said in my little caption here, given that there is a similar efficacy, we should let our patients decide according to their particular preference as to what they start with. As I mentioned before, it may be that there is a synergistic benefit between psychiatric and psychological approaches and hormonal approaches, but we need better data to look at that. So what about hormone therapy? This is one of the staple treatments that we've been using in our unit for many, many years, pioneered by John Studd. There are various different types of estrogen that can be used. The initial studies were with estradiol implants by Adam Magoth, and then Neil Watson and Roger Smith showed that you could achieve the same benefits with estradiol patches. Probably the best patches are the Estradot patches. These are the smallest ones, but you do have to start with a relatively high dose of 75 to 100 micrograms if you're going to achieve cycle stabilization. Remember, you're not just looking to replace hormones as you would in somebody who is going through the natural menopause transition. Another option would be to use estrogel, 2 pumps twice a day. And the accompanying progestogen or progestin, which is important if you're using estrogen, because if you use estrogen on its own, you will get endometrial thickening, hyperplasia, and even cancer long term, is to use a progestin or progestogen. Our preference is for utrogestan, which is a natural form of progesterone, which is typically used for 7 to 12 days, depending on how many days women can tolerate. The standard regimen is 200 milligrams for 12 days, but in some of our progestogen intolerant patients, we may only give it for 7 days. And in those women who can't tolerate the progesterone orally, they can insert it vaginally. The vagina doesn't contain the reductase enzymes, which converts progesterone to allopregnanolone, and therefore there tend to be less side effects for those women who are progesterone sensitive. Another option would be to insert a levonorgestrel intrauterine system, which is called a Mirena. There are other types as well. It is licensed in many parts of the world to provide protection of the uterine lining as well as contraception. I know that in the US it doesn't have a uterine lining protection license, but hopefully that will come along in due course. And it's also very good at reducing the heaviness and painfulness of periods. We're also looking at these smaller intrauterine systems, JDES and Kylena, which release lower doses of the progestogen as a way of still giving adequate endometrial protection, but less PMS, PMDD type side effects. And these do seem to be tolerated very well. And so far, the scans that we've been doing have not shown overgrowth of the uterine lining. But I must emphasize that they aren't, at the moment, are not currently licensed for protecting the uterine lining. What about GnRH analogs? Well, GnRH analogs are so effective that if GnRH analog therapy does not result in elimination of premenstrual symptoms, this suggests a questionable diagnosis rather than limitation of the therapy. But it's vitally important, I think, that if you're treating with a GnRH analog, which switches off the hypothalamic pituitary ovarian axis, drops the hormone levels to virtually nothing, that we replace hormones with a constant hormonal environment rather than a cyclic. Otherwise, you just replace cycle-related symptoms with menopause symptoms. And women on long-term treatment should at least have measurement of their bone mineral density every year or two to make sure that they are not being put at risk of osteopenia or osteoporosis. I sometimes start my patients on a nasal GnRH spray if there's uncertainty regarding use of the treatment in that individual, uncertainty either from the clinician or from the patient, but you do need a minimum of 3 cycles to assess response. And as far as add-back hormone therapy is concerned, probably my favored add-back therapy is transdermal estradiol, 50 to 100 micrograms, with utrogestan 100 to 200 milligrams. There has been some new research. Sepranolone is a GABA receptor modulator, which regulates the effects of allopregnanolone in the central nervous system. We participated in a phase 2 placebo-controlled double-blind trial called Azarina, in which women with confirmed PMDD were randomized to sepranolone or placebo. Although numerically the symptom reduction was greater for the sepranolone group, there in the purple, the effect wasn't sufficiently of a sufficient magnitude to separate it from the effect of placebo on symptoms. And as a result of that, sepranolone has not yet been licensed as a treatment for PMDD. It may be that we need to do more research. We may need to have a run-in placebo phase before randomizing as a way of eliminating that placebo effect. But at the moment, we can't recommend this as a routine treatment for PMS, PMDD. And then not to forget about surgical approaches, because we do have patients who have a vast improvement in their symptoms if the ovaries are removed. Clearly, childbearing has to be complete or childbearing is not desired. Remember that hysterectomy alone is not enough because we can get cyclic symptoms in the absence of menstruation. So I think it's important that the population for this procedure are carefully selected and they have the correct procedure performed. The other important thing is to ensure that we give adequate add-back hormone therapy. And if we don't do that, then we just replace one problem with another. Now, one of the really interesting phenomena which has occurred over the last few years is women continuing to experience symptoms which they liken to their PMS, PMDD, even after surgery. And it has proven to be a bit of a conundrum for us. What I have found is that for those women using gels and patches, when I switch them to implants, which give higher, more consistent estrogen levels, much of those symptoms actually did improve. So I actually think that replacing estrogen after surgery with a gel may not always be sufficient and may actually induce hormonal fluctuations, which can lead to persistence of symptoms even after surgery. So the WHO, World Health Organization, states that health is a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. And for this reason, I think we must continue to strive to improve the recognition and provide appropriate treatment to women affected by premenstrual disorders. And these are my key messages. I think in an ideal world, we would have universal adoption of the International Society for Premenstrual Disorders diagnostic criteria, because I think actually they are probably the best diagnostic criteria that we've got. I think it was a landmark decision that the WHO added PMDD to their International Statistical Classification of Diseases, and PMDD now has its own ICD code. The best evidence thus far is for the contraceptive pills that have the best hormonal components, but also the shortest hormone-free intervals. And we have a number of pills that have a 4-day hormone-free interval now, and some that can be used back to back. And I think those are the most effective if the pill is to be used. Other options include the estradiol patches or gels, SSRIs, and GnRH analogs. I think the training of healthcare providers needs to be addressed at university level and also in the UK at Royal College level, so postgraduate level, because at the moment we have a very limited number of healthcare providers that can effectively manage this condition from an evidence-based perspective. And I believe that we need a multidisciplinary approach to managing this condition with involvement of primary care physicians, gynecologists, psychiatrists, psychologists, dieticians. You know, we all need to work together to find solutions that can be truly individualized, because one solution does not necessarily work for everyone. And in the UK, this women's health strategy offers some hope that the required resources will be provided, but we need to keep lobbying politicians about this. I'm sure for this group that have logged on, I don't need to expound the virtues of IAPMD. It's a great organization that I'm honored to be affiliated with. Please do have a look at the website if you haven't already. I think it provides a vital lifeline for support of sufferers, for information and educational research, and also this project looking at patient-centered outcomes with the Research Institute grant. And our organization in the UK, that's our website. We have RC experts, scientific meetings, also webinars, our guidelines, and we collaborate. For instance, we collaborated with the Royal College of Nursing to provide this fact sheet on PMS, PMDD, which I know that many of the nurses found very helpful in managing their women. And with that, I'd like to leave you with this one of Van Hoch's depiction of the sunflowers, which leads me to believe that he had some understanding of the female menstrual cycle. You see the overturned sunflower in the premenstrual week, the blossoming within the first week of menstruation, and the two open sunflowers in the two mid-cycle weeks. Anyway, I have no idea whether he was thinking that or not when he painted this, but it does seem to fit very well. With that, I'd like to say thank you very much. Happy to take any questions. I think you're on mute, Tori.
Wonderful. Thank you so much. I'm sure if we were in a room together, there would be applause. Oh, good. We have some applause down there. Thank you so much. That was wonderful. And we do have 14 questions. It's 9:43. So I just want to warn everyone, we may not get through these, and if you add more, we may not get to them. You can add additional questions, but it's unlikely that we'll be able to get to them by 10 o'clock. So
I'm happy to take questions post hoc, so by email.
Okay.
You know, if you could.
Sure, by email. Okay, so just keep that in mind, everyone. We'll do our best. Okay, so what I'm going to do is I'm just going to start at the top and go down, and if anybody has submitted more than one question, just for fairness, we'll skip the second question and then come back at the end if we have time. Okay, the first question from Eden is, can we prescribe GnRHA to people who are breastfeeding following a pregnancy? Would it stop the breastfeeding?
Yeah, I mean, we wouldn't recommend GnRH during breastfeeding. Actually, women, whilst they're breastfeeding, tend to have a fairly suppressed cycle anyway. So they usually don't require additional cycle suppression. But we don't have a good evidence base for the safety of that.
Right. Okay, Lee asks, are you using the estrogen patch and oral micronized progesterone at any stage of reproductive life, perinatal excluded?
We are using it at any stage of reproductive life. So we use it sometimes even in adolescents going through puberty who are really struggling, although they tend to prefer the pill because they're more familiar with that. And right up to menopause. Postnatally, there tends to be a preference for psychiatrists to use antidepressants. But once breastfeeding has been established, one of the things that you can use if they are cycling, if the cycle has returned, is hormone therapy with natural hormones, what I refer to as body identical hormones, with estradiol and progesterone, and that doesn't suppress breastfeeding. So, it can be used at any stage.
Yeah, I'm going to go ahead and add my question here. If I could take that liberty. And this came up in the chat as well. In the States, in my clinical experience, everybody wants to try this estrogen protocol, right? Transdermal estrogen feels more natural, right? There's a lot of potential benefits. In our experience, it does not, 100 micrograms per day transdermal does not suppress ovulation in the States. And I am wondering is it possible that we've even had several people test and they all ovulate on it. So my question is it possible that there are potency differences? Are you typically using the gel as opposed to the patch at this point? We're just kind of trying to figure this out because we fully believe the data that were published by John Studd, right, showing that it does suppress ovulation in the UK, but then it's like, well, that's not working here. And I've talked to several providers having the same experience. If you have any insight as to why that would be.
Well, the first thing I would emphasize is that when the studies were first done with transdermal estrogen, when the studies were first done, they were done with implants. Then,
right.
So high dose hormone implants.
Mm-hmm.
We then moved on to 200 microgram patches as the standard dose. There was then a study which compared by Roger Smith, the 100 to the 200 microgram dose, and found similar efficacy, but with less estrogen side effects.
Yeah, so I saw that. And I was like, what?
Amazing. Yeah. And that was the reason for recommending the 100 microgram dose. And in Roger's study, there was ovulation suppression shown.
Yeah.
Now, my experience, if you like, and we also have some data that isn't formally published, although we presented it as an abstract for 100 micrograms. But my experience is that quite a lot of women do need to have an increase in the dose of the patch in order to achieve full effectiveness. So they may have some benefit, but we often do have to increase to 150 or 200. I wouldn't say that the gel is any more effective, but sometimes there can be absorption issues as well.
Yes.
And some women will absorb patches and not gels, and others will absorb gels, not patches, and some will absorb neither. And that's where we use the implant. And I think it's important, to look at the levels, look at the symptoms, and then make a decision what the best way forward is. But I can understand why in some studies they may not have found sufficient efficacy from the 100 microgram dosage.
Yeah. Okay, thank you. That's very interesting. And I think what we really need is safe. I think providers over here are very unwilling to go beyond the 100 microgram per day threshold. And I think a lot of that has to do with the women's health study. I mean, there's a lot, right? But I think we need.
Well, it's a very different group of women who,
yeah,
we mustn't, the Women's Health Initiative study was looking at women with an average age of 63, women as old as 79, given relative overdoses of hormones
totally different
for their age group. This is a group of young women who would normally be exposed to hormones anyway, natural hormones, and all we're doing is modulating the way in which those hormones are released. So instead of that, what we're trying to achieve is that. So the other thing to say is that even at the 200 microgram dosage, we do not produce unphysiological levels of estrogen. So the levels may be somewhere between 400 to 600 picomoles per liter, maybe up to 700-800, but certainly within the female physiological range.
Right. Okay, thank you for answering that. That's very interesting. We, spoiler alert, have some positive data from my clinical trials in PME of depression with estrogen, and so I'm really interested in thinking about how we can think about long-term safety.
And
with
Claudio
that.
Suarez as well, who's published in the US on depression.
Yes. Yes. Okay, next one. Kathy says, hello, I'm a UK-based psychotherapist. Would you be able to advise how long clients keep their symptom diary before going to a GP? Maybe let's start with that one.
Well, ideally at least one cycle, but in the studies that were done, we would normally recommend 2 cycles, as one may not be typical of what's going on. And look, I mean, I suppose the other question which might follow on with that, from that, would you ever refuse to treat somebody who hasn't got a symptom diary? And that would depend on my certainty from what she has reported as to how cyclic her symptoms are, the severity, etc., and whether we could wait for those documented symptoms before starting treatment. Right. I think as far as research is concerned, we need those documented symptoms at least for a couple of cycles.
Yes. Yeah. And I that distinction also created the CPAS, which is just a way to score. I think we mentioned this maybe.
Sorry, I lost you there. I think the line was a little crackly.
Oh, I was just saying, we have this standardized CPAS way of diagnosing the daily ratings, and really, if I could go back and take any mention of possible clinical implications out of the discussion, and I think they're pretty passive anyway, but I think it really is a research tool, right? It's too rigid for a clinical setting. Okay, and then just the question about, could you say more about CBT? What should be a focus here? So I'll take this one. The CBT that's been trialed is very general, just very kind of broad skills for emotion regulation, kind of hygiene. So I would say we desperately need mechanistic work to understand what kinds of cognitive or behavioral interventions might actually be possible or useful here. I think there's some evidence that a broad approach might be beneficial relative to nothing, but I think if we're really going to kind of distill an efficient, effective cognitive behavioral intervention, we need to understand the cognitive and behavioral mechanisms first, and we really don't have that evidence base yet. Okay, Lexi Bell says, we've had anecdotal evidence in the US that magnesium has been helpful. Are there any studies in the UK that would show that there is benefit?
There's certainly some studies showing an effect on sleep and having a sort of general calming effect, but I'm not aware of good studies looking at PMDD with magnesium. But I don't know whether, Tori, you've come across any publications on it.
No, most of them are sort of retrospectively reported, symptoms, which is fine. But I think, again, for a research perspective, or for the research evidence, we need to know that it's not just sort of a general positive effect, that it's actually addressing the cyclicity, I think, before we would recommend that. Yeah. Okay. The next one, did I? No. Okay. The next one is Kristen. Is there any evidence for Wellbutrin, so that's bupropion, being added to a continuous SSRI during the premenstrual phase?
Look, I mean, bupropion is something which I use off-label in my patients who complain of low libido, in whom psychosexual approaches have not been successful. There aren't other issues which may be causing low libido and can be added to an SSRI, standard SSRI. But whether that actually improves PMS, PMDD or enhances the effect is another story. Now, we know that one good way of suppressing libido is putting somebody on an SSRI. So I think it's something which I think is a useful adjunct, but again, I don't think there are any data showing that it enhances the PMS PMDD effect, but it may certainly improve quality of life for women on SSRIs.
Yeah, so I just looked, and there is one clinical trial showing that it does not beat placebo for PMDD. So I agree. I think it's sort of like a
Right.
a thing to address the side effects of SSRI, or maybe, but yeah, maybe not a first line thing. And it makes sense, right? Because bupropion is not primarily serotonergic, which, you know, we think that's part of how that works. Okay, next one. Abby says,
yeah, it's dopaminergic, yeah, so not serotonergic, yeah.
Would you be able to comment on the causes of PMDD? Is it due to hormone fluctuations or reduced estrogen?
So it's due to a vulnerability, which is most likely genetic, which means that some women respond adversely to a fall in estrogen levels, as well as the rise in progesterone levels. But I think you'll agree, Tori, that qualitatively the phenotype varies.
Yes.
There is a significant amount of variation whereby some women actually do well with higher progesterone levels and find it therapeutic. And I think in order to improve the outcomes in our studies, we need to select our populations more cleverly. And I think that's where, and I think this is where, you know, the work that Peter Schmidt, David Rubinow, etc., we're doing, Ericsson in Sweden, Backstrom, etc., to work out, you know, the genetics will pay dividends in the long term, because then we can use pharmacogenetics to individualize treatment. But at the moment, unfortunately, there's an element of trial and error.
Yeah. Yep. And so my lab will have a second clinical trial coming out this year on people with PME of depression, showing that if you give estrogen, it basically, like, perimenstrually and menstrually prevents the symptoms, but it doesn't do anything for the luteal phase, right? So it's that surge,
absolutely, and that
and just talk
and that's where
clinical trials together. That's not going to make that.
And that's where, you know, I hope that in the future, you know, your labs will be able to continue that work and actually, because it's such a complex area, isn't it? To work out exactly why there is this incredible variation from person to person in their presentation. But I mean, you're definitely onto something, aren't you?
Okay, the next one, Andy, quote, those with, oh, this is for me. Those with PME of depressive disorders should not benefit from evidence-based PMDD treatments that work by producing low, stable endogenous steroid levels, so oral contraceptives, GnRHA, or by antagonism of steroid metabolite activity at the GABA A receptor. So that's something I wrote that I stand behind. I think those are fairly straightforward findings. So the oral contraceptive finding is Peters et al. Basically showing that in people with PME of depression who are all on SSRIs, if you add Yaz, it does not benefit them. Similarly, you know, there are many, I don't know, I think maybe 5 studies basically showing that GnRHA alone works for luteal phase confined PMDD, but if you start getting into the PME chronic worsening phenotype, then they do worse or the same. They just sort of reset at their middle or bad level when you put them on GnRHA. So I think this is this idea of there's a subset of people probably predisposed to depression that have a estrogen withdrawal sensitivity. And so if you do that, but anyway, they don't benefit. There's plenty of evidence for that. And then we know that in the sopranolone trials, in both cases, they see much better effects when they take the PME of depression people out. And the PME of depression people don't benefit, and the luteal phase confined PMDD people do benefit. So I think, again, this is getting at those different subtypes of hormone sensitivity where, I mean, that's my sort of linking this back to the conversation. Yeah.
The other area of interest is with GnRH antagonists. I've had some anecdotal reports of good results. Yeah, with RIACO, with add back hormone therapy, showing a good effect, which I think that's an area we need to look at as well.
Yeah, I totally agree. I think avoiding that surge, right? What is it? The sort of bump in hormones that you get on the agonists. Avoiding that would be really beneficial too. And if it could be oral, that would be what is the risk of making the coil GnRH analog, but inclined for coil analog.
Sorry, the line's breaking up again. Oh, no. Could you repeat that?
Yes. So is it mentioning the Mirena or GnRH analog, which those are pretty different, but in clients who are very 17 to 18,
the line is not good for some reason.
Okay, we are at time. Let me see this up. Does that help?
Yeah.
Can people hear me? Okay.
Yes, that's very good.
Okay, this is the headphones. Sorry about that. Okay, so we'll just do this one more real quick. Is there a problem in recommending Mirena or GnRH analogs in clients who are very intolerant to progesterone in the context of estrogen therapy, taking the oral micronized progesterone on days 17 to 18 alongside the estrogen? So basically, I think they're asking, is if somebody's sensitive to the progesterone, the oral micronized progesterone, would we also expect them to be sensitive to the Mirena? I think is the main question here, because the GnRH question is really, I think, the same. If you're sensitive to the progesterone in the other context, you're probably going to be sensitive in this context, right? But what about the Mirena?
It depends on the degree of sensitivity. So I find in some of my patients, it can have quite an adverse effect on them. I had one lady who went crazy when the Mirena was inserted. Had to have it removed within 24 hours. It just was absolutely terrible for her. But others seem to tolerate it quite well, and seem to tolerate it better than they do oral progestogens or even progesterone. The reason we started looking at lower dose intrauterine systems like Kylena and Jadeth is because I believe that they work equally well for the endometrium. You don't need as much progestin as you do as in the Mirena, but they are better tolerated. So the answer is it's always worth considering as an option. And so most of our patients who may end up having surgery to have the uterus removed because they're progesterone intolerant have tried a Mirena at one point or another hormone coil and not tolerated it very well, and that's why we end up doing the surgery. But we do definitely, we offer it as an option. But I think there's also still quite a lot of stigma against having coils. Some people just don't like the idea of having one. We spend a lot of time trying to reassure people that it's perfectly safe, and if anything, associated with a lower risk of infection, and that it improves periods and it improves pain, etc. Doesn't make these things worse.
Right. That's so interesting. I'm not sure that we have that same stigma in the US. There's quite rapid uptake of those over the last 20 years.
Interesting, isn't it? Cultural differences.
Yeah, totally.
Yeah.
One thing I wanted to mention around that is that, just to clarify, we're not saying that the Mirena itself is the treatment for PMDD because it doesn't suppress ovulation consistently, right?
it's rather something
No.
locally to like prevent.
Really important point. Absolutely. So the Mirena is there purely to provide protection of the lining, where we're using estrogen to suppress the cycle. Yeah.
Right.
But on its own, well, I mean, there are some data from a PhD, I seem to recall, that showed some improvement within the first year of having a Mirena inserted, because it does have a systemic effect within particularly the first few months, which can even lead to an element of cycle suppression. But that doesn't last. That's very transient.
Yeah, and it also is, a lot of people who get the Mirena or the hormonal IUD have severe pain, right, associated with their periods. So there can be some improvement in mood just related to not having that pain as well.
Totally, yeah. I mean, they may have adenomyosis, so endometriosis within the muscle layer of the uterus, or they may have endometriosis, which the Mirena is also very effective for. When it was first invented, if you like, late 80s, early 90s, and it came on the market, it really revolutionized gynecological management, and hysterectomy rates dropped by half.
Yeah. Oh, that's very interesting. Okay, well, unfortunately, I think many of us have to go. I did do a screenshot of the rest of the questions. If you want to follow up with Dr. Panay, you can do so via email. But also we will keep those questions and consider them when designing future panel discussions and speaker topics. So I'm sorry we couldn't get to everyone, but thank you so much, Nick, for a wonderful talk and for a great discussion. And thanks everybody who came. And yeah, we encourage you to check out the professional membership website. A lot of people come to the webinars, but don't check that out. So go check that out, please contribute. Yeah, wonderful. Thank you, everyone.
Sorry, just say thank you so much to you and the work that you're doing, and for hosting this webinar. As I say, you're doing amazing work, and look forward to collaborating with you in the future.
Thank you so much. All right. Have a great day, everyone. Goodbye.
Okay. Bye-bye.